So this particular one was, and 1 minute, let me get the view right. This particular one has been manufactured 42 years ago. One of the very original total hips from the original company, manufactured 42 years ago. And 1 minute, let me get the light right. Yes, now I think you should be able to see me properly. Unless it's too bright. I'll open it for you. And we will again show this to other participants when they join us. That is how an original Chandli hip was packed. There you go. And there is the prosthesis. The original Chandli prosthesis, which laid a foundation to the hip arthroplasty business. We have a cup also coming from the same company. There you go. And this will open when the crowd gets a little more. And then we'll start discussing about these hips. How many of you have seen or used a Chandli hip?
A little.
How many of you have seen or used a Chandli hip?
Not used, sir.
None of us. None of you.
Yes.
And have you seen the original Chandli?
No, sir.
So today you get an opportunity to see this. So this in itself is an interesting thing. Next is, let's look at the cup. I'll unwrap the cup for you. There we go. And that is a cup. We need to tear it off. Wait a minute, let me get a scissor or a nail cutter or something. Yes, Dr. Muhammad. There is a original Chandli cup. And the cup and stem will articulate like that. That the original Chandli. It's called a cobra stem, which had a flange to pressurize the bone cement. And this is how the hip would articulate. It has a very small head, which is 22.7 millimeters, that is 7/8 of an inch, and it's got a fairly thick poly. And the longest bone of this hip has been 45 years. And at 30 years, Chandli hips show a survivorship of close to 80%. It's a cemented hip, basic hip, the cheapest hip, but now has been killed because of commercial market. And no hip in the history has Do I hear any question? Muhammad.
হ্যাঁ, এত পরে লাগবে, আর কিছু করতে আবার খাতা লাগাইতে হবে।
I'm hearing some random conversation, not actual questions. And not enough people.
রোদ বললে ইনফেকশন হয়।
What is this Dr. Mohammad Anwar Hussain?
Yes.
অনেকই আছে, দাঁড়াইতে সময় লাগছে।
Tell Dr. Hussain.
এক বছর লাগবে। No.
Yes, okay. Tell me. Come, ask. Ashish came close to the camera, his voice came. This software works in such a way that whichever participant makes a sound, his face will come up as a speaker view. And other people will a smaller view. So, if you're not intending to speak, you mute the microphone. Whenever you intend to talk, unmute your microphone so that your face doesn't come up when somebody else is speaking. Am I clear? Rajkumar, you wanted a question?
Huh?
Rajkumar wanted to ask a question?
No, sir.
You raise your hand. If you press the button on the left, it means you're raising your hand and you want to ask a question.
No, sir. No question.
So ask me, if you want to ask a question, please feel free to ask. I'm muting the people whose sounds are disturbing us. And if you are not intended to speak, you can mute yourself. When you speak, unmute and then speak so that the rest of us can hear. I'm still getting people joining requests, but I think there's some problem with the bandwidth. Some people are not able to join, some people are joining and leaving. Dr. Mustafa, you have to say anything?
No, I don't see anything here. I'm good.
You're good, okay. Ashish Patel, you want to say anything?
No, sir.
Okay. Ajay Singh, you want to say anything? No answer. Muhammad Anwar Hussain,
Yes, sir.
you want to say anything?
No, sir.
Okay, now I'll start with the first lesson. That is a pelvic bone. And we are now going to learn about the pelvis. 1 minute. Okay. As you can see there, we have a pelvis and we look at the acetabulum. Where is it facing? Where is the acetabulum facing? With the acetabulum anteriorly towards you. Can you see that? Acetabulum is towards you. And that is anteversion. A normal acetabulum faces 15 degrees anteriorly, so that it has got a long posterior wall, short anterior wall. Whether you are doing a hemiarthroplasty or a total hip replacement, orientation is very important. In hemi, you don't replace the acetabulum, but in total, you replace the acetabulum. When you replace the acetabulum, if you put it, I'll take it up and show you. If you keep it this way, that the version is normal. because both anterior and posterior walls are matched. But now suppose you turn the hip like this. This is an anti-verted cup with a good posterior support. And this is a bad situation. This is a introverted cup, which is also called an open cup, which has a tendency to dislocate posteriorly. So, the cup should be maintained with the precise version so that the spaces around the acetabulum and the edge of the cup remain constant throughout, and that the cup is neither antiverted or retroverted. This should be the ideal position of the cup. If the cup is like this, it is called a closed cup. It is called an open cup, which means it is open posteriorly and the head can fluxate. So we must avoid retroversion of the cup at all costs. So that is the first important lesson. Acetabulum, antiversion of the acetabulum. Acetabulum component will be as inverted as the acetabulum, which is in the patient's body. And finally, the inclination should have more wall posteriorly and less wall anteriorly. Am I clear so far?
Yes, sir.
Is that clear? Good. Next is a femoral version. Now, this is the femur, like so, anterior part, that is a shaft and that is a neck. So, this angle is called the neck shaft angle. However, turn this way and you can see that from this long axis, the head is deviated away about 15 degrees away from the lesser trochanter. You can see the lesser trochanter here. This is a straight line.
Yes, I can see it.
Huh?
Yes, I can see it.
Yeah, so this is the straight line in the femur. This is deviated 15 degrees, which means the head also points anteriorly so that posterior subluxation is avoided in a normal hip, even when the patient does extremes of movements like squatting. So, our prosthesis should maintain this version exactly, which means 15 degrees away from the lesser trochanter. This is very important whether you are doing a hemiarthroplasty or a total hip arthroplasty. Is that clear?
Yes, sir.
Yes, that's clear, sir.
So once we get an idea about femoral and acetabular versions, we should attempt to match the versions as close as possible to the native version of the patient. So some female patients will have a very high degree of antiversion, say 17, 18, even 20 degrees. Certain male patients who are very tall and gigantic may have a lesser antiversion, say something like 10 degrees, 9 degrees. It is erroneous to have a standard of 15 degrees antiversion in all hips. Best is follow the neck. Identify the lesser trochanter, leave a little area of the neck when you cut it, and follow the neck so that the prosthesis you insert should be matching the way the neck deviates from the head. So you can see that is my shaft in one straight line and the lesser trochanter facing you. And this deviation of 15 degrees with the, you can see it very clearly. Here you can see the condyles and here you can see the, now if I keep the condyles straight, if I keep the condyles like so, my head deviates 15 degrees. If I keep my head straight, my condyles will deviate 15 degrees. So the orientation between this and this, the twist of the femur is called the femoral version. Am I clear?
Yes, sir.
Yes, you are clear, sir.
Third thing you have to see
Clear.
is the areas of the acetabulum which have got thick bone and the areas of the acetabulum which have got thin bone. So this area has got a very thin bone. This area has got a very thick bone. So whether we do a cemented hip or a cementless hip, all the holes are going to be made in this area, this horseshoe-shaped area, and nothing is going to be made here. It is erroneous to put screw holes here because it will open up. And here I have a pelvis which has been cut into half, and this shows the bone density. So if at all screws go, they should go this way. They should go this way. They should go this way. Not coming out from here like this. I hope you get this.
Yes.
Okay. So idea here is thickness of the acetabular wall. One problem is the key. Now, this is a cup which has been positioned with a cement with the anchorage holes in this axis, and that is how the cup should be circumferentially all around the pelvis, all around the native acetabulum, neither overhanging posteriorly nor overhanging anteriorly. Last point in anatomy which I want to clear today is the femoral medulla. So if you look at this, we have split the femur in middle like this, and you can see this is the isthmic area. The prosthesis to touch this cortex, not this cortex, which means we have to go way back posteriorly in the trochanteric fossa. When you use a box chisel or a starter drill, so that we should not ream like this, we should ream like that, and we get a valgus prosthesis with the bottom of the prosthesis touching the medial aspect of the femur. Is that clear?
Yes, exactly, sir.
So now we have learned about acetabular version, acetabular position, thickness of the acetabular wall to enable us to place the screws or the cement anchor holes, and also about the cross-sectional dimension of the femur to aim the prosthesis in correct valgus. The only rules of a hip that last a very long time are the components should be correctly positioned, cup should not be either horizontal or vertical, neither anteverted nor retroverted, but follow the patient's native version. The tightest femoral component should be used, and the distal most tip of the femoral component should be touching the medial femoral cortex, giving a precise valgus orientation to the hip joint. Is that clear?
Yes, sir.
If placed in this position, the hip will last for many, many years, and the patient will have a satisfactory outcome and function. I think we are nearing the end of the meeting time. It's 9:25. I'll give you some time for each of you to ask questions if you have. Today was just the start of the meeting. We couldn't get too many participants. However, many of them are still messaging me on WhatsApp saying that they couldn't log on to the Zoom. We may repeat a similar meeting next week where we'll go through the same points once more so that our colleagues who missed the meeting today would also learn about it, and we should do a meeting like this once a week to discuss and talk about the tricks and tips of hip arthroplasty. Likewise, once a week, I also want to start knee sessions. Now I want the participants to please give me their opinions, suggestions, or questions about today's small session. Ajay, come on. Ajay, say,
Sir,
Gaurav, come
yes,
on.
sir.
Tell me.
Hello.
Yes, Gaurav, tell me. Gaurav?
Hello.
Ashish. Yeah, Gaurav, come on, speak. Speak up, speak up.
Good evening. Good evening, sir.
Did you listen to the whole thing? Or you joined late?
Yes, I joined late, sir.
Okay, okay.
Today
Okay.
I was in surgery, sir, so I joined late today.
Okay. So next
Yes,
week,
sir.
we can start. You can get it from the beginning. Okay.
Yes, sir. Sure, sir. I did the bipolar today.
Okay.
Bipolar fixation today. So
Wonderful.
I rasped in a inner aspect of the GT. So the process is in the good fitting now. When I was starting in first time, then I'll just not put it a rasp in the inner side of the GT. So same will be in a varus position. So now today I did the
Wonderful, wonderful. The trick is you have to go
Yes.
as far back posteriorly as possible in the trochanteric fossa to get the right valgus bed prosthesis. Wonderful.
Yes, sir. Yes, sir.
Ashish, come on.
Thank you, sir, for today's talk. I understood you said the angle of anteversion, how to follow the neck to get the correct placement of the prosthesis. My professor used to tell me all these things while at the time of the operation, but I always used to get confused and did not dare to ask him again. And today I understood it nicely. Thank you, sir.
Thank you very much. Thank you very much. Rajkumar, are you hearing us?
Yes, sir.
Yes. What's your
Yeah,
comment?
sir. Yes, sir. I cleared really with the anatomical bony specimens, sir. Like anti-version, all those things, concept got cleared, sir.
Wonderful, wonderful, wonderful. Ajay Singh ji, boliye.
Sir, we should go edge for edge posteriorly in trochanteric fossa or edge for edge laterally in the
As far
trochanteric
as
fossa?
posteriorly.
Posteriorly it should be.
Automatically the prosthesis, see, when we are going with a broach,
Yes,
we
sir.
want a posterior approach to get through the isthmus
Yes,
to
sir.
hit the medial cortex.
Yes, sir.
तो अपन
Oh,
end on से देखेंगे तो medial lateral जा सकते हैं.
अच्छा अच्छा
Your end on view should be anteroposterior so that you are able to do a medial lateral position.
Yes, sir. Yes, sir. Of course. And
Mustafa, comments please. Dr. Mustafa, Egypt. And who's left? Dr. Muhammad Anwar Hussain. Your comments, please. No, he's a listener, silent participant. And Mayur Patil.
Hello, sir. Good evening, sir.
Yes, Mayur. Your comments about today's thing?
So it was a very informative session. Looking forward to more steps of the surgery.
Thank you all.
Thank you.
Thank you very much. Zoom on 30 minutes for meeting, and I think we are exactly on the 29th minute. I thank you all very
Thank you
much
so much, sir.
for participating.
thank you, sir.
Thank you very much.
Thank you so much, sir.
Goodbye.
Thank you, sir.
Thank you so much, sir.